So, thank you, madam. Thank you, sir. I think with this, we'll start our meeting officially. Let me invite Dr. Thomas Alexander, sir, to start his first presentation. And let me also invite our panelists to take the chairs.
Yeah. Good evening. Thank you, Lawrence and Sybil, for this opportunity to launch this, and I think our first in-person meeting in probably a couple of years' time. So, welcome everybody. What I'll try to do over the next probably 10 to 12 minutes is to give you a brief overview of the current guidelines on AF. And I'll rely primarily on the ESC guidelines to take you through it. Now, this is the global prevalence of AF. And if you look at data from 2016, we talk about something close to 43 million patients across the world with AF. And today, we know it's close to 60 million. If you look at the data from India, you will see that we have something between 600 and 700 per 100,000. So that's a huge burden of AF patients that we have, that we need to decide how do we manage them. Do we look at rate control? Do we look at rhythm control? And if we are looking at rhythm control, are we able to use some of the new technology that is available today to control their rhythm and get them back into sinus? Now, this is again data from Europe. If you look at the lifetime risk of AF, 1 in 3 individuals will develop atrial fibrillation. And this, I think, as our population ages, we're going to see this sort of numbers here. Males are more common. And if you look at the elderly, you can see that the incidence is fairly high. And this is something that we're going to face in our own countries. But what is more important is that as you look at the risk factors, if there are multiple risk factors, you will see that the incidence of AF progressively goes up. Now, we know that 1 to 2% of the general population have AF, but if you were to look at the developing countries, we now know that as the population ages, we're going to see a huge burden of AF in our population, and this is going to be a huge challenge from the management perspective. But more importantly, if you look at data from the cardiac implantable electrical devices, you see that 43% of patients have detectable AF, and that's defined as more than 6 minutes of AF. So that's a huge burden, and many of the cryptogenic strokes that you and I see is probably related to AF. And it's just that our diagnostic capabilities are not adequate today for us to make this diagnosis that we're missing these patients. Now, when you look at the clinical classification, you define them as asymptomatic patients. That's basically silent AF. And these are patients who do not have a hemodynamic compromise. Or you talk about symptomatic patients who might have symptoms, basically palpitations, dyspnea, and fatigue. These are the commonest symptoms. And they could be hemodynamically stable, but you do know that there are patients who become hemodynamically unstable, particularly those with LV dysfunction or patients with critical coronary disease. When they get into AF with a fast ventricular rate, you will find that many of these patients become critically ill. And if you look at outcomes, and I think this is very important, mortality rates in patients with AF is about 1.3 to 3.5 times that of normal patients. Stroke, I think this is the biggest worry for all of us when we have patients with AF. The decision whether to anticoagulate or not these patients, because stroke, I think, is one of the worst things that you could have in a patient with AF. Patients presenting with heart failure, again, LV dysfunction patients, you suddenly find them decompensating when they flip into AF. And one of the things that many of us do not know or do not take adequate care to investigate is those who come to us with cognitive disorders, those who come with what we call as dementia. And many of these patients are probably patients who have AF, either microemboli or cerebral hypoperfusion resulting in this. And knowing that the sort of incidence of AF in the general population, I think these are things that we need to keep in mind. Depression, quality of life, I think these are important things that we need to remember when a patient comes to us saying, I'm fatigued, I'm fatigued. Are these patients in intermittent or persistent AF? And these are things that we need to clearly look at. In terms of diagnosis, I think it's important for us. This is basically an ECG diagnosis that you make, where you have an irregular RR interval and absence of a distinct P wave, resulting in an irregular atrial activation. Clinically, you would divide them into symptomatic and asymptomatic AFs. And these are the definitions. When you have a patient that you diagnose first with AF, you diagnose it, you call it first diagnosed AF. You don't know at this stage whether it's paroxysmal, whether it's a persistent, or it's a long-standing persistent AF. An AF which either self-terminates or is terminated by drugs within 7 days, you would define that as paroxysmal. Persistent is up to 1 year, and long-standing persistent is beyond 1 year. Now, we often have this diagnosis of permanent AF, and I think this we need to remember is a terminology that is a therapeutic attitude of both the patient and the caregiver, that we're going to accept this AF as permanent, and we're only looking at rate control, we're not looking at rhythm control. But again, we do know that today, if for a GP or for a general cardiologist, it might be a permanent AF, but if he sees a electrophysiologist, maybe he would look at rhythm control in that particular patient, and then you need to actually reclassify them as long-standing persistent, because he might want to attempt to convert this patient back into sinus rhythm for whatever reason. I think some of the terminologies that are not used, lone AF, we know that many of these patients have multiple underlying reasons for going into AF. Valvular, non-valvular AF is a terminology that is not the ESC fields should not be used, though I think that it's still a very useful definition, because once you say valvular AF, particularly if it's a patient who's had a valve replacement or a mild or a moderate to severe mitral stenosis, it at least tells us that this is a patient who should be on warfarin or acetylene rather than on a NOAC. And I still would feel that this is an important definition that should still be retained. If you look at the risk factors, there are multiple risk factors which are non-modifiable: age, genetics, ethnicity, and male sex. But there are multiple other risk factors that you need to look at. And this is important whether you're doing a rate control or a rhythm control, in order to make sure that these patients long-term are able to stay in whatever either controlled rate or in rhythm. It's important to make sure that these risk factors are also taken care of and they are treated. Now, one of the ways that the AC now talks about looking at AF is what is called a structured characterization of AF. And this is the 4 S that it talks about. And this is important for us clinically. The first is the stroke risk. How does one say that a particular patient has a high or a low stroke risk? And this is by using the CHADS-VAS score. And I think one can classify the stroke risk. The second is to look at the symptom severity, and we define that as asymptomatic or symptomatic. So that's a second important characteristic. The third is the severity of what you would call the AF burden. And this could be a temporal pattern in terms of the definition that we just used, paroxysmal, persistent, or permanent. Or it could look at the AF burden in terms of number of minutes or number of hours per hour, depending on what you use for measuring. And finally, looking at the substrate severity, and here you would look at both the risk factors as well as atrial disease to determine whether this is a patient worth trying to get him back into a normal rhythm. There are multiple ways of AF screening, and today with the smart watches that most people today walk around with, I think this has been a tremendous step forward. And I think many of our patients might come to us saying that we have AF, what do we do? And I think that's going to be a challenge both for the clinician as well as for each one of us practicing to decide how do we treat these patients? Does it require treatment? But clearly, this is going to be a new population that's going to appear before us with either symptoms or no symptoms, but telling us that here is my watch and this is what it shows. In terms of diagnostic workup, I think all AF patients, you do a medical history, a 12-lead ECG, a transthoracic echo, and this, I think, is a basic workup that is required. I think going a step forward, depending on what one decides, is it rhythm or rate control, you might need to do a more detailed workup. I'm just going to touch upon 2 or 3 important aspects of AF management. One is the question of oral anticoagulants. I think we just discussed that people with either a valve replacement or a moderate to severe mitral stenosis should be, if you decide to anticoagulate them, should be on vitamin K antagonist. If on the other hand, they do not or are typically non-valvular AF, the first question that one needs to ask is what is the stroke risk, and this is using the CHADS-VAS score. So if you have a 0 in males or 1 in females, it would be, you would tend to not use oral anticoagulants. If they're on the highest side, then do a Hasbled score again. This is not to tell you that if you have a high Hasbled score, you would not anticoagulate, but if you have 3 or more in a Hasbled score, I think it's time for you to look at what is the reason for this high score and look at trying to reduce the risk of bleeding in these patients, but it wouldn't stop you from putting them on anticoagulants. So if you have 1 or 2, that's 1 in males or 2 in females, I think it's optional to use an oral anticoagulant, and some people would use an antiplatelet agent. But if it's more than that, that's more than 1 or more than 2 in women, there is a clear indication to use a NOAC in these patients. In terms of rate control, in which situation would you use rate control? I think if you have a patient who has virtually no symptoms, it's a first choice therapy in patients who have no symptoms. In patients who have failed rhythm control, or the risks of doing rhythm-controlled treatment in some of these patients is very high, then you would look at rate control in these patients. So there are 2 limits that we need to remember. The benign limit is less than 110 per minute, and if they're still symptomatic at that, you would want to bring them to less than 80 per minute. The drugs of choice are, of course, beta blockers, diltiazem, verapamil, digoxin, and in some situations, you would look at amiodarone. In terms of rhythm control, again, this is purely in a patient who has symptoms or quality of life issues. In just lowering rate is not adequate. Again, I think if symptoms are present and you think the symptoms are related to AF, then I think you need to do a workup to decide, is this going to be a successful conversion, and are these patients going to remain in sinus rhythm long term? And many of these are the younger age group, if it's a first history or there's already a very short history, the left atrial size is small, you've treated all the other risk factors. There are multiple factors that would tell you that, yes, this particular patient has a high chance of coming back into sinus rhythm and staying in sinus rhythm. And those are the patients that should be targeted to get them into sinus rhythm. A word about cardioversion. If a patient is unstable, clearly you would cardiovert immediately. If a patient is stable, if he's already on oral anticoagulant, then it's safe to either do medical or electrical cardioversion. If the AF is more than 48 hours, then you would need, if possible, to anticoagulate them for 3 weeks before cardioverting them. And if it's urgent enough to do it early, then a TE is required to make sure that there is no LA appendage clots before doing a cardioversion. So, and I think I can't emphasize more that the risk factors that are responsible for AF, whether it's hypertension, obstructive sleep apnea, increased alcohol intake, hyperlipidemia, smoking, obesity, these need to be kept under control, not just for preventing AF formation, but also for making sure that AF, when converted to sinus rhythm or when rate controlled, will be a long-term success. Thank you for your attention.
Thank you, Dr. Thomas, for giving us an overview on the atrial fibrillation, right from the epidemiology onto the management. I think we are actually seeing an aging population now, and as rightly pointed out, once somebody touches the age of 80 years, it's perhaps as high as about 10%. And even not only that, I think another area is heart failure. So I think we've been doing some work, and then we've seen that this is really climbing up. Close to about 10% of patients now develop AF. And that's indeed a very, very challenging situation. Sometimes you have a patient with significant heart failure on various drugs, and then at this point of time, to tackle this and also to control the rate as well as the rhythm becomes even more difficult. My question is, are we really, the diagnosis being really that easily followed in the general population, at least in the general physician's level, is it being picked up? Sometimes we see that an EKG can really bring out this diagnosis, but then time and again we have seen patients coming to you quite late in the course of the disease. So I think what could be done in the current era of smartphones and smartwatches? I think it's easier, done than said about it. What is your message to the physicians from this perspective?
Well, I think it's very clear that a lot of atrial fibrillation, whether it is paroxysmal, is missed in many of these patients. They present with heart failure, they present with stroke. So clearly there's been a period where they could have been picked up, they could have been anticoagulated or managed at that point in time before they reach this critical or even tachycardiomyopathy. Again, you see these patients come with LV dysfunction. They are in AF at this point, and you're not sure whether they were, if they were picked up early enough, many of these could have been prevented. So I think this is a huge challenge. But I think with a fair amount of public education, by engaging with physicians, I think we should be able to at least sensitize them to the fact that AF is something that needs to be looked at. And with the smartwatches that are available today, I think this is going to be the way forward, is what I would feel. Maybe, Sybil, you could add on to that. In the West, are patients coming to you saying that I've got AF, what do I do with this?
Smartwatches are an excellent tool, and the newest technology on smartwatches already give such a good quality on ECG that you can nicely differentiate the distinguished P waves. So you can nicely see, is it an atrial tachycardia, is it flutter, is it atrial fibrillation? So it's not like a couple of years ago where we just looked, okay, there are QRS complexes, they're irregular, should be AF. but time changed, and I think this is honestly the future. But there's also something else. This is also for the physician more work. Every physician will get in future maybe in their Outlook account 100,000 of online ECGs, which we have to look up in future. But however, for the patient, it's good.
If I can just add a question here, what about the AF burden? I mean, when would you start worrying? Somebody comes to you saying, okay, I've got a 30-second AF. Is that something that worries you? Or somebody says, I've got a 2-minute AF. Where would you start worrying?
Okay, this question has been answered in these guidelines nicely. We talk about AF after 30 seconds. So before we had different definitions in the last 10 years. Some pacemaker guidelines said, okay, 6 minutes, irregularities or whatever, then we talk about AF. But you asked me personally when I get worried and when I would take any action to treat the patient. We have couple of data in the last, we got a couple of data in the last 2 years which showed nicely that even asymptomatic AF patients with short episodes will profit from sinus rhythm. I will show this in my presentation later, and what do I mean with benefit or beneficial of sinus rhythm in patients with asymptomatic AF? I mean cardiovascular comorbidities or complications in the future, and tachymyopathies, everything, because short episodes asymptomatic, these patients won't feel it. So, with other words, if someone has AF, 30 seconds, I wouldn't go for ablation in this patient, but I would tell the patient, okay, this is something we have to treat and which can be a problem in the near future, and I would look for the Chet's score and I would go talk with the patient what he wants, because once AF, always AF. After the first episode, the second, and the episodes will come shorter and shorter.
Regarding this AF etiologies, it's a thyroid assessment also very important for our general practitioners. Because last month I have one patient with AF fast ventricular rate found to have a hyperthyroidism. Just initial presentation itself will be AF in hyperthyroidism. And regarding starting the treatment for AF, sometimes they will have mild symptoms with AF. After starting the treatment with the rate control or rhythm control, sometimes some people who had a tachybrady syndrome, they will land up in syncope. So more than this AF, the drugs reveal the underlying sick sinus syndrome. That's also very important for a diagnostic aspects.
I think there's something in the context of remote monitoring. Today in the COVID times we talk about remote monitoring, and I think a lot of, as Dr. Thomas has mentioned, the devices have given us a lot of information on the AF burden in the population. But then there's an interesting study which has shown that some of them once you pick this up and then they are prompted to go to the hospital, and aggressive treatment has actually led to worse outcomes. So I think there is a trade-off there. So I think we also need to look into that aspect. Of course, there's not a large data, maybe a few hundred patients studied from all the remote monitoring from the devices. And so that's another thing which you also need to keep in mind. So all AFs, even sometimes very aggressive, I don't know. That's also has a negative effect sometimes. Your comments on that?
No, for sure. Aggressive treatment is always not good. The study you mentioned is a very interesting study indeed, and honestly, I would agree 100% on that. So at the end of the day, and this is what I deeply believe, the patient decides. The patient decides what he wants. If he wants to be treated, we can consult, but the patient has to decide. And if he wants to be treated, we have to treat him. even if he's asymptomatic and if it's a short episode. And we counsel him. And if the patient say, okay, I don't want this anymore in my life, we can say, okay, go for antiarrhythmic treatment, just for example. You will have recurrence rate of 70%, or go for an ablation treatment, you will have recurrence rate of 30%. So I agree, aggressive treatment is not good, but at the end of the day, the patient has to decide, and this should be the most best way into, from my opinion.
Sir, in our country, the prevalence of the said chronic permanent AF is very high. Do you think still a short of an ablation will change the course of disease, or you think, what do you say?
I think we still have reasonably high numbers of patients with valvular disease. So I think a lot of our chronic AFs could still be valvular AF, and I think we shouldn't forget that. In terms of
non-valvular.
Yeah. So the question is really, I think as more and more facilities come in terms of ability to ablate these patients, I think many of our patients who have a label of chronic AF will probably be relabeled as persistent AF, and I think many of the as newer generations of EP cardiologists come into practice, I think we will be seeing a lot of these patients at least being attempted to convert to sinus rhythm. I think one other point that maybe you would like to touch on is one of the commonest drugs that is used, whether it's for rate or for rhythm control in this country, is amiodarone. And I think the use, maybe you need to touch on this, because I see so many of our patients coming back, or coming to us first time. It's only rhythm, it's only rate control that is being attempted, but they're on amiodarone, and this is something maybe you need to talk about.
Yeah, thanks. This is indeed a very, very important point. If you ask me, amiodarone is poison. It's a good drug, but it's poison. We are living in the year 2021. You have now the console here. And we have so many options to treat a patient. If you decide to go for rate control, why do you give him amiodarone? This does not make any sense. You destroy the lung, the eyes, the thyroid, all these organs. This does not make any sense. Give him beta blocker, give him digitalis, and go for rate control. If you want to do a rhythm control, we have other options. The main problem with amiodarone is indeed that the side effects will come at the end, and that the compliance of the patients is not good. And from my personal experience is, if you start with amiodarone too early with these patients, you mentioned after the first episode, you lose a good option for the future once the patient will get older. And you cannot give him any more flecainide or all the other drugs. And he already has problems with the thyroid or with his lungs and so on. And you already, the patient was already on amiodarone, and it is right now ineffective. So what is left? What can you do then? Then you can go only for pace and ablate, destroy the AV node and give him a pacemaker. So amiodarone is a good drug, but we have to give it in an intelligent way to the patient, and that's what I think is the best.
I think we'll go to the next.
Good evening, all. I think when I was preparing for the presentation itself, one thing which strike me also, like I'm presenting on AFib for a reasonable period of time. The most common topics we tend to present on AF is rate versus rhythm control. This is supposed to be the topic which we are presenting for I think more than a decade now. And if we leave and come away from this topic, we'll end up talking something about stroke prevention and atrial fibrillation. So I think for a change, we'll talk about something which is going to change the course of the disease rather than trying to deal with the complications of the disease. So I'm going to talk about how we are going to treat early the patients who are presenting with paroxysmal AF and make them in sinus rhythm in most of the time. So we know very well atrial fibrillation is a disease with a lot of consequences. Close to two-fold increase in the death overall and around 9-fold increase in the risk of death within 4 months after the first AF diagnosis, particularly in elderly. Close to 5-fold increased risk of stroke, increased risk of heart failure and sudden cardiac death. Along with that, we know a lot of these patients present to us with multiple episodes of fast ventricular response. You put them on drugs, they go into bradycardia and fatigue. You try to manipulate the drugs a little further, another episode of fast ventricular response comes in. So there are a lot of negative impact on the energy level, physical activity and overall quality of life. So to understand what we are dealing with, we need to know the overall course of this disease, how the disease progresses over a period of time if left alone untreated. So this is how the atrial fibrillation progresses. The patient is asymptomatic with very infrequent episodes or as Dr. Shibu mentioned, very short episodes of less than 20 seconds, 30 seconds. Hardly patient can identify the episodes. From that they slowly progress to a paroxysmal AFib. Few episodes, patient presenting to the emergency with fast ventricular response, most commonly terminated within 12 hours, 24 hours of hospital stay, intravenous amiodarone or cardioversion, goes back with either a oral dose of an antiarrhythmics or rate controlling drugs, and slowly over a period of time, it goes into a persistent phase, and at last, you ultimately develop a lot of remodeling in the atrium and it becomes a permanent atrial fibrillation. This is one side of it. And you can see, when you look at the lower one, you clearly see over a period of time, there are a lot of things happening at the atrium at pathophysiological level. So there is a lot of atrial remodeling which is happening. Okay. So a lot of atrial remodeling happening. Slowly AF progresses, ultimately leads to the consequences and the comorbidities associated with atrial fibrillation. And more importantly, you see what happens to the ablation, which is a curative treatment for atrial fibrillation in the early phases. As the patient progresses from the proximal phase into a permanent phase, literally your ablation success rate goes down, which was more than 90% to start with in the proximal phase. It goes down to a 50-60% success rate at the late onset. And you know very well, at a permanent AFib, the ablation strategy also becomes very complicated. In early stages, we know atrial fibrillation has only few triggers. Most common trigger, I think one of the phenomenal paper which came from one of the Indian origin electrophysiologists from Swiss, Dr. Dipan Shah, the phenomenal paper where they identified the atrial fibrillation triggers start from pulmonary veins. So one of the most common areas from where pulmonary veins start firing, you have a sleeves of muscles covering pulmonary veins into the atrium. These sleeves can be arrhythmogenic, and the pulmonary vein starts to have a lot of fast action potentials, which ultimately generates more of atrial fibrillation waves, which can come into the atrium and degenerate, and patient develops atrial fibrillation. So initial treatment started that because most of the time triggers remains pulmonary veins, you go inside the pulmonary vein, you just isolate them from the atrium electrically, so that if by chance your pulmonary veins remains arrhythmogenic also, no impulse enters from the pulmonary vein into the atrium. So this started the early part of ablation strategy in atrial fibrillation, a pulmonary vein isolation. It's a very simple strategy. You just go around the pulmonary vein, just electrically isolate them with the radio frequency, and patient is having free of atrial fibrillation. But the problem is this kind of strategy will not work in later part of the atrial fibrillation, because as the atrial fibrillation ages, you will have more and more atrium participating in the triggering activity. Your atrial remodeling happens, your atrium gets dilated, not only the left atrium, your right atrium starts having a lot of triggers, your SVC can triggers, so your coronary sinus can produce a lot of atrial fibrillation triggers. So ultimately you have a disease which is literally affecting every part of the heart. So when you are going to deal with that kind of atrial fibrillation, your procedure becomes more complicated, your success rate comes down dramatically. So when you are in early, it's very easy for you to treat them with a very high success rate, with a lesser complication rate, and you remain very safe also. So this is what happens with a very busy slide. You can see that you have multiple loops happening in the atrium when the patient develops atrial fibrillation. That's an electrical loop where you will see a lot of electrophysiological changes happening at the atrium. The trigger loop, as I told you, the multiple levels of triggers start firing over a period of time. The structural loop where you develop dilating left atrium. Slowly your left atrium stretches. The more it stretches, you develop a lot of heterogeneous areas of conduction. AF becomes persistent to permanent, and you have a hemodynamic loop where you lose atrial compliance. Your atrium starts dilating more and more, and you end up creating more and more triggers. And this continuous loop runs over a period of time, and patient ends up in a permanent atrial fibrillation. So as I told you, in early part, you have very few triggers. Patient presents to you with a PAF, and the more and more time you leave them, ultimately patient develops more and more triggers, and it becomes more persistent to permanent, and ultimately really difficult for you to manage them with whatever strategy you are going to follow. So how the AF is going to progress? You will have a first diagnosed episode of AF. A lot of your patient presents in the early part of their clinical presentation with this. Slowly, these proximal episodes, the duration increases. The patient was converting with amiodarone within 6 hours. Now it takes 24 hours for them to convert. It takes more than 48 hours for them to convert. And ultimately, amiodarone doesn't work. You cardioverted them a few times, and the episodes becomes more frequent. He was having an episode once in 2 years. Now it becomes once in 6 months and once in 3 months. And slowly you will see he's in AF all the time. Ultimately, you ends up going to a long-lasting, persistent to ultimately a permanent atrial fibrillation. So what changes when a patient changes from a paroxysmal to a permanent site? A lot of changes happens in the patient lifestyle also. You see, if you look at all the studies, you clearly see all the studies show progression from a paroxysmal to permanent, averaging from 7.8 to 72%, 77%. So the few studies are quoting that close to 77% of the patient who initially presented with proximal AF ultimately ends up in some form of persistent or permanent form. So average around 34-33%. So pretty high number. Close to 1/3 of the patient whom you have seen as a proximal AF will ultimately end up having a permanent AF. So what happens? What changes when it changes from the proximal to a non-proximal form? You see what happens here. A patient had a proximal atrial fibrillation, and look at his all-cause mortality. When he becomes a non-proximal AF, the mortality significantly increases. So when you have a non-proximal AF, there was a significant increase in the all-cause mortality, and cardiovascular mortality trended higher in non-proximal AF group. The moment the patient changes from the proximal group to the non-proximal group, there was a significant increase in the mortality overall and cardiovascular mortality. So you look at one of the largest trial, the Rocket AF trial, which looked at huge number of the patient with atrial fibrillation for stroke prevention with rivaroxaban. In Rocket AF study, they had close to 14,000 patients who had a AF. Around 18% of them were paroxysmal and 82% were persistent. So in paroxysmal, AF patient had a significantly low all-cause mortality, low incidence of stroke. If you look at the composite endpoint of stroke, systemic embolism, and death, all were significantly lower. You look at these two curves, they are completely diverging. This is a persistent and permanent AF arm, and this is a proximal arm. You can see that they are diverging from to start with. When they followed over a period of close to 30+ months, there was a significant increase in all these complications in patients who had non-proximal form of atrial fibrillation. So most of the trials you see, as your atrial fibrillation ages, the more time the patient stays in atrial fibrillation, the atrial fibrillation we know very well. I think we have read, every one of us have read AF begets AF. So the moment AF comes in, if you are not going to treat them aggressively, this AF is going to progress further. It's not the disease which is going to stop at some point of time. It's not like any other arrhythmias. We see a lot of other arrhythmias which we treat. You see a AV nodal reentry or some other form of arrhythmias. We know these arrhythmias stay, their frequency may increase, their intensity may increase, but they don't cause significant changes pathophysiologically. But AF is one arrhythmia. When it moves from proximal to persistent to permanent form, there is a huge changes which have already happened in the left atrium. So what happens? Beyond mortality, we know definitely there is an increase in mortality. You see, beyond mortality, there is a 2.5-fold increase in the cardiovascular event rate when you compare with permanent with proximal AF. 6.5-fold increase in the risk of stroke. Around 2.5-fold prevalence of heart failure. Close to 1.5-fold increase risk of hospitalization for cardiovascular problems. And more than 3-fold increase in electrical cardioversions or stroke or TIAs. Overall, the quality of life significantly decreases the patient who moves from proximal to persistent form. So we know very well now that this is very important for you to stop the patient from moving from the proximal to persistent form. How we are going to do it? How we are going to prevent progression of atrial fibrillation? There are a lot of data available. So this was a big data, came from a worldwide prospective study on AF management. Close to 2,130 plus patients were looked upon with proximal AF. Close to 318 patients progressed, close to 15%. AF progression from proximal to persistent AF at 12 months were significantly lower when we used rhythm as a strategy compared with rate as a strategy. So when you try to bring the patient to sinus rhythm, most of the patient remained in proximal form more than when they allowed to be in a rate control strategy. I think when we are talking about rheumatic atrial fibrillation, there's an excellent paper which came from Yash group in, from Mumbai, where they tried recurrent cardioversions for patients who had rheumatic atrial fibrillation. That strategy was to bring the patient to sinus rhythm in rheumatic AF. So one of the very difficult substrate where you have to bring sinus rhythm back. But when they did, I think it's a study was over a period of close to 3 years, when their arm, which they were aggressive in bringing sinus rhythm, was the arm which was doing extremely well in the endpoints. So more and more you bring the patient to sinus rhythm, they do well. And we are not talking about rheumatic AF here. We are talking about a non-valvular AF or it's a proximal AF where you have multiple strategies for keeping this patient in sinus rhythm. These strategies will definitely bring down associated mortality and morbidity. So when you look at another option, you know very well we have another option available other than drugs now, which is the catheter ablation. When catheter ablation became available for managing patients with paroxysmal AF, you can see progression. There is a significant drop in the progression of atrial fibrillation from paroxysmal to persistent form when the ablation was attempted either by a cryo or by a radiofrequency in these patients. So you have an option of treating this patient with drugs. The problem with, we know very well, the rhythm control drugs, we have limited choices. I think amiodarone, I think in India we have only amiodarone, flecainide and propofol available commercially. And amiodarone is most commonly used drug. The usage of flecainide and propofol is very limited, not only because of physician related issues, the availability is a big issue. I use flecainide a lot, and most of the patients will complain over a period of 6 months that drug is not available, including our own pharmacy, which is one of the largest pharmacy available. There also that getting a drug, flecainide, is so difficult. So propofol, when we start propofol on some patient, it's very difficult for them to procure from, including Chennai. A lot of time the patient has to procure from Mumbai. So availability of antiarrhythmic drugs is very limited in our country, although a lot of drugs are manufactured in India. So if you look at progression, you can see that definitely whenever you have a ablation group which is compared with a pharmacological group, already we have seen one group, pharmacological rate control versus rhythm control. The rhythm control patients do well. When you are looking at a rhythm control as an option, you can see ablation doing extremely well compared to pharmacological management. Your antiarrhythmic drugs, they don't do well. You see here, the ablation group, you look at the progression, it is 0.6% per year, while in pharmacological group, it's close to 9% in first year and close to 25% in 5 years. 1/4 of your patients who have been kept on, I'm not talking about a rate control strategy, the patients who are kept on pharmacological rhythm control strategy progressed. 1/4 of your patients have already gone into a persistent or permanent form where you may not be able to offer them further management options, including ablation, when they come back to you after 5 years. So if you look at systemic review in general population, it's again a repeat of what I've told you. This is an interesting one. So when you are going to treat them aggressively, how you are going to time that. So if you look at this study, you can clearly see the moment you are in the early part of atrial fibrillation, your results are always better. All your endpoints are much better when you look at early versus late. All the patients who have been treated earlier tend to do better. You postpone including your ablation later and later, your outcomes are not good. So for atrial fibrillation, like any other disease, you treat early. We know about most of the diseases which we see in clinical practice. Most of the diseases do well when you treat them early part of the disease. You go in the later part of the disease, whatever you want to do, your results are not going to be suboptimal. So another one is a fire and ice, where they compare radiofrequency ablation and cryoablation as a strategy for managing these patients with atrial fibrillation. So in this study also, you see here, each additional year between AF diagnosis and ablation procedure was associated with a 3% increase risk of repeat ablation. So the more you postpone the ablation, the higher the chances is patient is progressing to more towards persistent or permanent form. Not only that, you ultimately you end up doing an ablation, but the patient is going to come back more often if you are going to do it later. To summarize, atrial fibrillation is a progressive disease. Progression of atrial fibrillation increases risk of death, stroke, heart failure and cardiovascular events and hospitalizations. These outcomes we know very well definitely contribute to a decreased quality of life and ultimately leads to progression of atrial fibrillation. Rhythm control drugs, we know the drugs available are more effective than rate controlling drugs for prevention of AF progression. So I started saying that we were doing a lot of early studies, early presentations on rate versus rhythm control. I think now that question has been reasonably resolved now. Whenever you have an AF, your primary strategy has to remain rhythm control. Either you achieve by drugs if you don't have an option of doing an ablation, or if you have an option of doing an ablation in an eligible patient, as a rhythm control strategy, ablation should be always preferred. So catheter ablation is more effective than pharmacological rhythm control for the prevention of AF progression. So you have two statements which are very important. So rhythm control is the management of atrial fibrillation when you compare rhythm and rate. When you have rhythm control as an option, catheter ablation is much better than a long-term antiarrhythmic drugs. We know very well the drug which is most effective among three available, amiodarone, you cannot control for long. You cannot control for long, or you can continue for long. I think a lot of time we get a discussion on amiodarone as a drug. It's a very difficult drug to pull out also. Most of these patients who are doing well with amiodarone, you are worried about amiodarone on long term, you just pull the amiodarone 100 mg out of patient's prescription, patient comes to us with a recurrence. So when you have reached a stage where a patient has nearly become amiodarone dependent, the drug has to be continued nearly lifelong with all the consequences of amiodarone toxicity. So earlier ablation after AF diagnosis and an antiarrhythmic therapy is associated with improved long-term outcomes, including AF recurrence, repeat ablations and death. To put little more perspective, we do a lot of ablations as an electrophysiologist. We do AV nodal re-entry ablations, we do pathways. We know these are all very successful ablations. We do. I always tell my patient when they come for an AV nodal re-entry ablation, if he comes back again to my OPD, I'm a little worried. I don't want to see him again because he's cured. He will never come back to my OPD. So AF is not going to be that kind of a disease. AF is going to be a disease because it has multifocal triggers. You can have other triggers, you have risk factors, a lot of other things happening in the atrium. So these patients may not be completely cured of AF when you do a radiofrequency ablation or a cryoablation, but definitely your chances of stopping a progression of an AF from a persistent to a permanent form will be much better if you attempt an early ablation. Maybe early ablation with an antiarrhythmic drug for a period of time may help. There are some patients whom you may pick up very early that you may be able to offer a cure also. A patient who has a proximal AF, just a PV trigger, one pulmonary vein or two pulmonary veins firing, and you just get a good PV isolation with a good radiofrequency or a cryoablation, then patient is going to do incredibly well, but you are going to ablate later, but still you are going to achieve better overall prognosis and overall progression to a persistent or permanent form than giving an antiarrhythmic drug. So if you want to treat atrial fibrillation, you have to treat him here. So this is the place you have to treat atrial fibrillation. So this is the best time for you to treat atrial fibrillation with whatever strategy you are planning. If you go anywhere after this, your management is going to be really difficult. Most of the patients will ultimately end up in a permanent AF, which will be, you see, like you will end up putting do an AV junctional ablation, put a pacemaker, the patient comes back to you with LV dysfunction, recurrent admissions with fast ventricular response. So this is going to be a mess here. So if you are going to manage most of the patients in this part, you are going to stop a lot of these patients going to this phase, and you are going to do really well, and patients are going to be really managed in a much better way. I was supposed to make another presentation. I think because we are short of time, I'll stop with this. If there are any questions, I'll be happy to answer. Thank you.
Way we treat AF right now?
Yeah, definitely. I think ibutylate is a drug which is like amiodarone. It's good for an acute conversion. Although acute conversion rates of ibutylate, in my personal experience, are not as good as amiodarone, but it's supposed to be a safe drug. Particularly patients who have a borderline blood pressures and you are not very keen on cardioverting them to start with, I think ibutylate is a good drug. But as I told you, it's a short gap arrangement. It's like an adenosine for a SVT.
Yeah,
so when the patient,
that is exactly. See,
yeah.
you load amiodarone, you wait for.
Yeah. It's an excellent drug for an acute conversion. If it works, I think it works close to 60 to 70% of the time. If it is a proximal AF without much of a structural issues, ibutylate works nicely. While amiodarone may work on little more structural damaged heart also. Like when you are with amiodarone, I think if you have a dilated LA and a lot of these groups also respond. With ibutylate, the patients who have a typical proximal AF, there's normal LA, first episode, second episode, they do extremely well. Second, your post-op atrial fibrillations, your post-acute like kind of a patient admitted for the sepsis and all that kind of. Only thing is you have to be careful about your QT interval. So you have to be. The patient has to be monitored very closely for QT interval because amiodarone does not cause that much of tossets. We know very well amiodarone, although prolongs QT, does not cause that much of tossets. So you have to be very careful. These patients has to be admitted. You cannot treat them like adenosine. So you have to keep them for 24 to 48 hours in the hospital. Otherwise, it's a nice drug.
How does this post-op AF behave? Do they behave similarly like paroxysmal AF, slowly going into AF, or they are a different?
See, post-op AF or AF secondary to a systemic disease, all these have a reversible component. So when you are going to reverse the primary cause for this atrial fibrillation, these patients do extremely well. So they like your post-MI atrial fibrillation. Like you know, post-MI atrial fibrillation is secondary to a raised left ventricular end-diastolic pressure or atrial infarction. So these patient movement you are going to treat, they are going to do really well. Most of the arrhythmias, all the arrhythmias literally, when they have a reversible component, they have to be reversed and you have to wait. If the patient has a structural disease, which ultimately lead to a post-op AF, it will come back after some time. Then you can treat it like a AF, which you usually treat. Otherwise, post-op AF is a trigger which has to be treated.
Yeah, Dr. Lawrence, I think you have beautifully conveyed the message that catch them young and treat it adequately. You know, there's an overwhelming data to support the early treatment with cryoablation, and then you get the desired results, and I mean, the data is so evident. But I have a little different perspective to the whole thing. Now, I was inclined to think that, you know, if you have a young patient with a structurally normal heart, and then getting frequent episodes of paroxysmal atrial fibrillation, and then, you know, symptomatic at that point of time, these are the candidates who do very well in the long run. You ablate them, and it's like, I mean, you forget about the disease altogether, and that's perhaps the areas that you should really be aggressive. But another subset of patient is I think there is a different therapy altogether. I'm sure you'll also agree on this. We have a elderly population who come with sick sinus syndrome. They come to you sometimes with a brady and sometimes with the atrial fibrillation, very fast rate. And the moment you put in a pacemaker there, and you start pacing these patients at a, let's say, atrial rate of 70 or so, they never get an episode of AF at all. So I think it's a different scenario where, you know, you can offer a different therapy for atrial fibrillation. What's your take on that?
Yeah, so like whenever I counsel a patient with typical tachybrady syndrome who present with signs of sinus nodal dysfunction along with atrial fibrillation, I always tell them that there is a possibility of two diseases in you. One is a pure sick sinus syndrome, which has a component of atrial fibrillation, which definitely will go off if I am going to pace your atrium. So this is the one subset. That's definitely another subset who have a sinus nodal dysfunction and atrial fibrillation as a structural disease. These AF will come back. So not all the patients who have a sinus nodal dysfunction with atrial fibrillation have sinus nodal dysfunction as a cause of atrial fibrillation. But when they have this as a cause, they do well. But it's very difficult to identify them. See, when I attend most of the European meetings, like when they present the scenario, I always get tempted to say, like, they will ask you a question, put a sinus nodal dysfunction with atrial fibrillation. They ask me, like, what you are going to do now? You do a AF ablation or a pacemaker? So for me, a lot of time I feel like I will put a pacemaker first. But most of the audience and most of the people who do radiofrequency ablation, I think Dr. Sibu also will somewhat towards that direction. They feel like ablating atrial fibrillation has value. Today we had a case, I think a doctor who has a clear-cut feature suggestive of tachybrady kind of a situation. We ablated that guy for an atrial fibrillation with a cryo today. I told him also, like, there's a possibility that you may require a pacemaker post, because I don't know how your sinus node is going to behave post RF. So you have to see his post RF ECG. All that sinus bradycardia all vanished. So slowly they improve, sinus node improves. But this is a different patient altogether. The sinus nodal depression in this patient is secondary to atrial fibrillation. The AF which is coming again and again, it's depressing his sinus node. So this man will not be benefited by a pacemaker with a atrial pacing. The AF will come. But if AF is a component of, as you told, a 75, 80-year-old male, female comes with a signs classical of a sinus nodal dysfunction and has an atrial fibrillation, I would never ablate that patient. I would just put a pacemaker and wait. And I would manage atrial fibrillation medically if it comes back. I feel that way. Like, I think we had enough discussion on that most of the times, and I see also a lot of my patients doing extremely well with this.
Does the left atrial size matter when you choose patients for this cryoablation? And second thing is, how is cryoablation different from radiofrequency ablation? Is it different scenarios?
I think we have a good talk by Sibu after this. Still, I'll just mention it. Like, I think there is no clear-cut level at which you should not ablate atrial fibrillation. But you know very well when you have reached a dilated LA and a permanent AF, your success rates are going to be dramatically low, but still in the range of 60 to 70% in most of the data. But what happens is, here your pulmonary vein isolation alone will not work. You may have to do a lot of substrate modification in the atrium. You may have to ablate some at sinus, CS, somewhere in the right atrium. You may have to do a lot of lines. You may have to do a perimetral line, and all that you may have to make. And larger ablations you do, the higher the chances that patient have a lesser success rate, more complications and recurrence. So when you choose a patient with a larger left atrium, you may have to be aware, and your patient also to be aware that there is a chance of recurrence is high. If you want me the exact number, I usually look at 4.5 millimeter, 45 millimeter as a level at which I feel this is going to be tough to keep in sinus rhythm. That's the thing. If you ask me radio frequency versus cryo, as I told you, we know very well now from data available that PV isolation or pulmonary veins are the source of AF in most of the patients. What we do is we electrically disconnect pulmonary veins from the left atrium. The electrical disconnection can be done in two ways, one with a heat, one with ice. So heat, what we do is we take a radio frequency catheter, we make multiple burns, we connect all the burns and form a circle so that this pulmonary vein get isolated from the left atrium. It's a tedious process, takes longer time, and one vein isolation may take, maybe in some patients with a not good contact, may end up doing somewhere around 1.5 hours, even on experienced hands. So, but success rates are as good as cryo if you do a good ablation. But cryo, what we do is, we have a mapping catheter which goes into the pulmonary vein. We have a cryo balloon which is available. Only thing you have to make sure is the balloon has a good contact over the pulmonary vein. You occlude the pulmonary vein in such a way that there is no gap between your pulmonary vein and your balloon. If you are able to achieve that, the cryo balloon will release the gas which will cool the area and create a circular ablation. So in a single burn, you will create a good circular ablation. So only prerequisite is you have achieved a good apposition of the balloon, which may not be possible in a lot of patients. Today we have two patients, one patient we are able to achieve a good apposition in most of the veins, and second patient we really struggle. So it's not like every patient will have that. If you have a good yearly proximal AF with non-dilated LA with a good pulmonary veins, there's a high possibility that you will achieve this with a shorter time. So cryo can make your AF ablation somewhere between 4 hours into a 45 minutes to 1 hour procedure. I think people like Sibu who regularly do, I think they will go in and come out in 45 minutes to 1 hour time. So it definitely cuts down your time. Always, like any cath lab procedure, we know very well the more you stay in, the higher the chances you develop a complication. So you stay lesser in the left atrium, short procedure time, safer, and results are as good as radiofrequency ablation. The non-inferiority trials have clearly shown that cryoablation is as good as radiofrequency ablation efficacy-wise, while all the complications are lesser with cryoablation when compared with radiofrequency. I think we'll go for next talk. So we'll go for next talk, and if anything left, I think we can discuss later.
Oh yeah, that's why. Okay. Take this one off. What happened here? Okay. So, good evening once again, dear Chairman, dear Organization Committee, dear colleagues. Thank you very much for the kind invitation. Very happy to be here. And as you heard, we already had a long day, so I would guess you are hungry. So I will try to give my best to keep to be in time. I think we heard a lot about AF today. AF is a disease with a huge incidence. We heard it in the last two presentations. The incidence is increasing eminently in the last years, and also the cost for our healthcare systems, but also for the patients. And this is everywhere in the world like this. And we know we don't have to go too deep into this, just to keep in mind, because we talked about this today several times. This is a disease mainly of the older population. So most of AF patients are over 70, over 80 years old. But we still have a lot of patients with atrial fibrillation between 60 and 70, and even younger patients. And these are the patients we have to focus on. We have to try to find a way to treat these patients adequately. Dear colleagues, let's think together. What is the rationale or the best way to treat a patient with paroxysmal atrial fibrillation? I heard that most of you are cardiologists, and many interventional cardiologists and many referring physicians. So just consider patient with paroxysmal atrial fibrillation, not too old, maybe 45 years old, completely healthy, but he's symptomatic. If you ask me, I would refer him for catheter ablation. What would you do? I would guess maybe the same, maybe you would give amiodarone, okay? So the drug, I heard flecainide is not ubiquitous available here, so you would give drugs. We have new AC guidelines, and the guidelines are that what we should follow. So what do the guidelines say? The guidelines clearly say consider patient choice at first. Either go for catheter ablation or go for the go for antiarrhythmic therapy. The new thing in the recent guidelines is that it has a class 2A indication for paroxysmal atrial fibrillation. And the very new, and this is really something fundamental new in the last, which happened in the last, was implemented in the last guidelines, we have a class 1 indication after failed therapy. So, and I think this should be, and this is based on a lot of evidence. We should treat these patients adequately. These are our guidelines. So, we had paroxysmal atrial fibrillation. These are the patients we have to target mainly on. Persistent AF, if they do not have to, we heard about in the first presentation about the risk factors. If they do not have too many risk factors, these patients will also have a beneficial effect. They will profit from a rhythm control. Permanent AF, I wouldn't touch interventionally, just straight control. And what about patients with heart failure? I think this is all in India a huge problem. Patients with heart failure. Look into the guidelines. They say antiarrhythmic drugs or class 1 indication for catheter ablation. These patients, we had the CAST Life trial, which has been published in the New England Journal 3 years ago, I'm sorry. And this trial showed a tremendous benefit for the patients once they get sinus rhythm back. What should we do? Catheter ablation. You can do a lot of things in the left atria, but the guidelines are very clear. Once you go to the left atrium, just isolate the PVs and don't do anything else. This is what the guidelines say. But what is the reality in the world? The reality is, as we discussed today, 40% of the patients are asymptomatic. We have symptomatic patients. And how many patients are really treated annually? 4% by a catheter ablation. This has different reasons. One reason is, we heard about that, these are complex procedures. Patients are afraid. Referring physicians maybe do not know too much sometimes about these procedures. So there are a lot of different issues. However, if you do it in a correct way, these patients will have a good effect on that. So we heard about that. In most of the patients, the trigger for atrial fibrillation comes out of the left atrium. Just please have a look on this picture, on these two pictures. This is the left atrium. You have a view from posterior, from the back to the left atrium. You see here the septal pulmonary veins. They are cut off in this picture, but however, here it's not cut off, right superior, right inferior. So these are septal pulmonary veins, lateral pulmonary veins. In the back, you will see the left atrial appendage, and here would be the mitral annulus. So, And within these pulmonary veins, there are the triggers. This is what we heard in the previous presentation, where Deepan Shah and Professor Heiseguer from Bordeaux find out if you isolate the veins, these patients will had a great, tremendous effect on getting sinus rhythm. So these are the triggers which are perpetuate and initiate and perpetuate atrial fibrillation. So if we talk about atrial fibrillation, I make this one short. If we talk about atrial fibrillation and ablation, we have to know, you have to know how the recurrence rate are. Because it's very easy. Your patient will ask you, if you want to send him for ablation, your patient will ask you, okay, doctor, what do you think? Will I get AF back or not? And your answer is then, 46%. This sounds horrible. This is not the answer. The answer is, in a long-term follow-up, 20% of the patients might have a recurrence. So the key message is, if you want to go on the track for catheter ablation, cryo, RF, the patient has to know that you potentially need more than one ablation procedure, possibly, and statistically, it's 1.5. So 1 to 2 ablation procedure to get rid of atrial fibrillation in paroxysmal atrial fibrillation. So 80% after 1.5 procedures and only half of the patients after one procedure. And this is very important for the patients. Otherwise, if the expectations are that high, you will lose your patients, and the patients will say they do not know anything about medicine. I don't trust you anymore. So this is a very, very important aspect, that the patient knows that it can come to a recurrence. Yeah, that's what I said. And if you look on the long term, one procedure, only 30% after 10 years. Just think about 10 years. We have now the year 2021. We started on a routine base with catheter ablation, PVI, maybe 2008. So there are not too many long-time follow-up data. And in this study, this is one of the studies of my old hospital, after 10 years, 60 to 70% stable sinus rhythm. And I think this is a pretty good result with, don't forget, and I said long-term follow-up, 10 years, with old technologies. These patients were not treated with the newest generations of balloons or with the newest generations of 3D mapping systems. These are old generations and less experienced operators. You heard about it. Why do we talk about recurrence of AF? Very quickly. So you see here, this is again a left atrium from behind. This is the septal pulmonary vein. What we do? What do we do? We mark the ostia, just for example, and then we give current, radio frequency current, and we make a line around the pulmonary veins. We isolate, and then we do it on the other side. And maybe after 2 hours, the PVs are isolated. But where is the problem? Why don't you have, just for example, every 10 kilometer between Coimbatore and Chennai, 100 EP labs? This is not too easy to do. There are a lot of limitations. These are very complex procedures. Just think where the heart is. The heart is behind the lung. If we breathe, our patients breathe. They are not, we don't do the procedures in apnea. They breathe. So the catheter will move also with the lung and with the heart. And if the catheter moves, you don't have a nice catheter tissue contact. If you don't have a nice catheter tissue contact, you won't get a nice necrosis, a transmural lesion. And what happens? Somewhere here maybe, the tissue recovers. And if the tissue recovers, the patient gets a recurrence. This is why we are talking about 80%, one of the reasons. It's a long learning curve. You need good operators who knows how to do. And that's what I said, it's sometimes very challenging to create good transmural contiguous permanent lesions. It does not make sense to ablate here, 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 here. That's why. The EP world was seeking for a single shot, I would say single shot device which is much more easy to handle. And this is, just for example, the cryoballoon. The procedure is basically the same. You start from the groin, a venous puncture, nothing complicated. You puncture the groin, you have one diagnostic catheter in the coronary sinus, you go up with a long sheet, do the transeptal puncture. So it's the same like before. But now, you don't have to do for many hours the 3D map. You see here, what is this? This is the balloon which comes out of into the left atrium, and these are the pulmonary veins, and you have here a spiral catheter. With this spiral catheters, you can see the potentials of the pulmonary veins, and once these, I show you later, once these potentials disappear, you know the vein is isolated, and I did my job, I'm done, and the patient, he will feel good. So, you target these pulmonary veins with these catheter or spiral catheter. You inflate the balloon, and the next step is very easy. You just push the balloon against the antrum ostium of the pulmonary veins. You give contrast medium, and if the contrast stays there, you know you have a perfect occlusion, and then you are almost done. Just hold it there and start freezing. Just cool down, and you will get temperatures below 40 degrees. Below 60, it's recommended to stop because one might induce collateral damages, but between 40 and 60 degrees, you will have a good result, and the PVs are isolated. And you have to do this 4 times for the left superior, left inferior, right superior, right inferior, and then you are done. And I think one might imagine that this is much more faster than doing a 3D map and visualization and ablation. This is similar to a simple coronary angio. Maybe a bit, yeah. Okay, good. Good. So basically, what happens with the tissue? What happens with the tissue? If you compare cryo lesions to RF lesions. I don't want to go too deep into that, but what you see at the end of the day that cryo preserve the extracellular matrix, and it does not denature the proteins. So with other words, after RF ablation, sometimes you see thrombus formation, which you do not see after cryoablation. It's more homogeneous. So everything what we tell the patient, this is a more soft operation, we see also on a cellular base. What about this is something, the data are old, but nothing changed on that. This is something your patient wants to know. What is the acute success? This is something the patient will also ask you. I go with AF to the hospital. Do I have AF the next day? No, because acute success is almost 100%. So it is very, very, very rare that you do not isolate the 4 PVs, or that you have to stop a procedure, or that you won't succeed. So acute success rates are very, very high. You heard already about this trial. I will do it very, very quick and short. This is the largest ablation study which has been ever performed all over the world. This is the Fire and Ice study, which gives us basically the evidence to do this. And this study compared one-to-one cryo versus RF ablation, and I do it very short now. It was a one-to-one randomization with 700 patients, and the outcome was, yeah, what was the outcome? Okay. That's interesting. There's no difference between the gold standard radiofrequency ablation. At that time, you just have to think there have been millions of ablations with radiofrequency and not that many ablations with cryoballoon. So there's no difference. Both are equal. And this study was never powered for superiority, only for non-inferiority. Everybody, so if this study would have been powered in a different way, the results might have been different. What about the safety endpoint? And this is something, so what your patients will ask. What about stroke after procedure? We are performing ablation within the left atrium. There's a connection to the head. Stroke risk intraprocedurally, very low. Of course, there's a risk for groin hematoma, of course. What about all-cause death? All these complications, very, very low. So at the end of the day, when is the best timing? We had to do either radiofrequency or to treat, I would say to perform a rate control treatment in the patients. When is the best timing? We heard about that in the previous trial. There's a progression from paroxysmal atrial fibrillation to persistent, to long-standing persistent, to permanent AF. And if we keep all these things in mind, in very clear cases, I would say as early as possible. In Latin, we would say in dubio pro reo, just for the patient. This is a study which has been published in the New England Journal at the end of last year, 2020. And this study is the biggest study on this topic, and this exactly analyzed this fact. It analyzed the usual care in AF patients, rate control versus early rhythm control, either amiodarone, flecainide, or catheter ablation. And what we see is that outcome in rhythm control is much better, or is definitely better than in usual control, concerning cardiovascular morbidities, complications, mortality. This is something else we have to talk about if we talk about cryoablation. This has been published in the New England Journal of Medicine this year, and then I'm almost done. I can see that you are hungry. Okay, as initial therapy for patients with atrial fibrillation. This was a randomized trial, 200 patients, one-to-one. Antiarrhythmic therapy versus catheter ablation. So we are back to your question. You have a patient with paroxysmal atrial fibrillation, 45 years old, first diagnosis. He never had flecainide, he never had amiodarone. What to do? Catheter ablation or drugs? I said amiodarone is poison, but if there are no other drugs, maybe amiodarone is not poison. So what to do? This was the question in this study. And this was indeed a very nice study. And this is the outcome. As you can see, cryoballoon was at long-term follow-up, 1 year, much more successful than antiarrhythmic therapy, 75 versus 45%. And these patients had event recorder, loop recorder implanted. So this is not the very weak Holter or 12-lead ECG follow-up. This was a good follow-up, standardized follow-up. This is also a question which would be interesting for every one of your patients. And also, if I'm a patient, I would be also interested. Because the patient, if he goes to a doctor, how can the patient know this doctor is good, he's medium, he's average, he's excellent. He cannot know. So, with other words, the patient would have a double benefit if the technology is that easy that results are reproducible, good, and not dependent on the excellence of an operator. So let's have a look. There are some interesting, I do this also slowly. There are some interesting studies which analyze this. Are the results reproducible? These are data from France. Couple of centers in France, and they do RF ablation, cryoballoon ablation. Every color stands for a different institution, and as you see, the ratio is different in every institution. And what you see, some institutions did more cryo, some institutions did more RF. And if you look to the left side, these are the cryo data, outcome data, and these are the RF outcome data. And here you see that the outcome in all the centers were completely different. And here it was pretty much the same in the cryo group. So, a short learning curve, reproducible clinical outcomes. There has been very recently, a couple of weeks ago, also another publication. I'm sorry, I was on the flight. I had no time to put that slide also here. But they analyzed really how many ablations a center performs and the outcome data. And there was, after cryo, it showed it basically was the same. There was no difference between both groups. So, from my side, ladies and gentlemen, take-home message. PVI, and this is something really new, is a class 1 indication right now. Okay. Catheter ablation for patients with atrial fibrillations. We have much more evidence right now that early ablation, RF and cryoballoon, ablation therapy is something positive for the patient. We have to stop progression from paroxysmal to persistent AF. This is something very important. We have, with the easy technology, we have similar outcome data after cryoballoon-based ablation procedures in less experienced centers or by less experienced operators. But this does not mean unexperienced. There's a difference between unexperienced and less experienced. You need a certain level of experience, of course. You need to be an electrophysiologist. Otherwise, it does not make any sense. So, I think I have my 30 minutes. I could talk 1 more hour. I think I would stop at that point and would say thank you very much. Thank you. Open for questions.
Thank you, Dr. Shibunade, for a very enlightening talk and also for bringing this technology to this part of the country. So I think it's a really promising and technology and really heartening to note that this is now available in a place like Coimbatore. Now, my question is, after you do a successful procedure, I mean, some of these patients would have been on an oral anticoagulant or a NOAC for that matter. How long would you continue this? Would it be 3 months, 1 year down the line? So what is the chance of somebody developing a stroke at the end of 3 months, 6 months if you discontinue the anticoagulants?
Yeah, it's a good question. Honestly, this is a question which has been discussed 2 years ago on many conferences because everybody wants to stop after successful ablation, the anticoagulation. This should be the target because right now, treatment says we do ablation, we give for 3 months oral anticoagulation, and afterwards we look for the CHA2DS2-VASc score and lifelong anticoagulation, even though the patient has been ablated. So concerning this topic, honestly, we don't have the results so far. But there are some trials running on, randomized trials, analyzing and comparing patients after ablation with discontinuation of oral anticoagulation, and continuation. So this means, I would guess, in 2-3 years we know more about that. But at the moment, nobody knows. So at the moment, so far, if we talk about our patients, I would continue.
And one more question is, we have seen CRT, helping us in terms of reverse remodeling and things like that. What happens to LA remodeling? So once you do not very early in the disease, but maybe once the LA is dilated a bit, and you think this technology will make any impact on that?
Yeah, there are some studies on that topic. There will be no remodeling. In an advanced stage, it doesn't make any sense anymore. So forget if the left atrium is 60. But early stage is maybe not the right point. But if you have a patient with a left atrium, not lavi or left atrium size of 45, and he has some scar anterior wall and posterior wall, and we analyzed this with my old group. I remember that very well. And there are also some other Japanese studies on that topic. And you can see in a certain number of patients regression of the LA size and less fibrosis along the anterior wall. But honestly, there are too many confounding risk factors which can, on the other hand, enlarge again, even though the patient is in sinus, or create fibrosis. This is what we had in the first talk about the risk factors for AF, because we don't know if there's a patient asymptomatic AF after ablation. So, but we have we have some data which showed already that left atrial enlargement can be stopped, and fibrosis as well. There are some data on that, yeah.
Apart from the access site complications, can you give us some more on what are the potential complications which I have to explain to the patient before I take the patient?
Very important. I always tell the patients, most of the patients do not know too much about catheter ablation, but most of the patients know what a PCI or coronary angio is. I always start and say, okay, it is pretty much similar like a PCI procedure. Then they know, okay, there's stroke risk, there's a groin complication, and then I usually say, okay, there's a certain reason for risk for pericardial effusion, tamponates, but this is with this technology pretty much low. So there's another complication which is with this, which might be a bit higher with single shot devices like the cryoballoon compared to radio frequency, and this can be a palsy of the phrenic nerve. So if this occurs, then the diaphragm on the right side won't move after procedure, and this can happen during ablation of the right superior or right inferior pulmonary vein. On the lateral side, not. The diaphragm on the lateral side goes epicardially, and here along the septal pulmonary veins. Important, and this is something the patient has to know. In most of the cases, the phrenic nerve palsy will disappear and everything will be fine already within the procedure. If not, in almost, I think, 70 or 60 or 70% within the next couple of months, and almost every patient will be fine after 1 year. So this is something which resolves after a period of time by itself. And most, this is from my personal experience, most of the patients are not too symptomatic with that. Symptomatic are patients, young patients who do a lot of sports, marathon runner or cycler, but the normal patient with a phrenic nerve palsy on one side won't be, in most of the cases, won't be too symptomatic. So this is something the patient should know. Yeah, the risk is 2 to 3%.
I think we had an excellent discussion. I think I would like to open this to the audience. Any questions from the floor? to all the three speakers. I think
Sir, we are in the process of working it out. So it will be costlier than the radio frequency ablation because there's a cost attached to the balloon. But we will keep it affordable. May not be very costly. Like I think outside India, cryoablation is AF ablation as such is a very costly procedure. I think in India, at KMCH, we'll keep it as very affordable. Exact price, I think we'll work on it.
How much it costs in Germany?
I think this should not the question. The procedure will be completely reimbursed by the German healthcare system. So the hospital will get a certain money for every PVI procedure. Either it's not important if it is the first PVI procedure or the 10th PVI procedure in one patient. 10 procedures doesn't make any sense, I agree on that. But however, it is completely reimbursed. And this is the main difference.
I don't think I may not be in a position to. But I think the kind of work we are going to do, I think it's not very costly. It's not very costly. Like whatever we acquired, it's not that costly. I think that's the reason I told that we can keep it at very affordable because most of the patients who are eligible for cryoablation should be able to afford it. I think I don't think it will be very cheap like a radio frequency ablation, but it will be definitely affordable.
How do you ensure the transmodality of the cryoablation? Especially in the wake of the fact that the antral osteal morphology and the thickness might vary from patient to patient?
You can take the question.
Okay, I take over. You cannot visualize it at that point. If you want to visualize, you have to do also a 3D map or you go for an MRI. But I think this is much expensive, doesn't make sense. So how can we be sure that, I show you, here, look here. This is the proof for us when a PV is isolated. This is the septal vein, this is the balloon. And just have a look here. This is the surface ECG. Everybody can see this is atrial fibrillation, ECG, irregularity of QRS complexes. And what you see here, these are the signals we get from the pulmonary veins from here. And we start with the freeze. And what you see here, the signal within the pulmonary veins gets slower. It gets slower and slower and slower. And then at the end, it disappears. And once it disappears, we know the pulmonary vein is isolated. If there's really 100% transmurality, only God knows. We do not know of. This is the acute outcome. Yes. Yes. You can see it only with MRI. If you want, you can see it only with MRI. Or you have to do a remap. You can remap the ostium, and once you see scarring around the ostium, then you're sure that you have a transmurality. No? Yeah. But if the patient wins. If the patient has no more symptoms and no AF, then the question is, you know what I mean? Yeah.
So I think if there are no further questions, I would like to thank Dr. Shibu, Dr. Thomas Alexander, and Dr. Lawrence for this wonderful session. And then on behalf of all the panelists, I'd like to hand it over back to the organizers. Dr. Lawrence, please.
Yes. Thank you. I think let me invite Dr. Mohan to give the vote of thanks. Thank you.
On this great occasion of this day, it's a very special day.
for the KMCH Heart Institute that which has been introduced first novel cryoablation system here in Tamil Nadu. So I would like to special thanks to Dr. Nalaji Palanichami, Chairman of KMCH, and as well as Dr. Tavamani Palanichami, Vice Chairman of KMCH, and as well as Dr. Arun Palanichami, who's been Executive Director of KMCH, for this wonderful opportunity to introduce this novel system to our KMCH Heart Institute to initiate this program actually. And so we had a very good CME on the novel methods of AV management, which has been organized by Dr. Lauren Jesuraj. He's been electrophysiologist of KMCH Heart Institute, and so very special thanks to him to initiate this program. And as well as we had a wonderful international faculty from Germany, and Dr. Shibu Matthew is the head of electrophysiology, medical department of cardiology, at University Hospital Gießen. To initiate this program and to start this with the 2 cases today, and as well as tomorrow we have 1 more cases on in KMCH. So thanks to Dr. Shibu Matthew, and as well as we had a wonderful talk from Dr. Thomas Alexander, the senior interventional cardiologist, as well as head of the department of KMCH Heart Institute, and with along the co-speakers of Dr. Lawrence J. Suraj and as well as Dr. Shibu Matthew, with the moderators by Dr. S. Balaji, as well as Dr. Suresh Kumar, Dr. P.B. Jayagopal from Lakshmi Hospital, Palakkad, and as well as Dr. P. Nathan, KG Hospital, Coimbatore. So as well as I would like to thank all the participants and those who have been interested as a cardiologist and the cardiothoracic surgeons and the general practitioners, and as well as internal medicine specialists and postgraduate, and as well as the other non-paramedical staffs to understand and knowing about this AF management, and as well as our KMCH other department colleagues to have this opportunity to see this wonderful system here. And again, I would like to congratulate and thanks to the KMCH, the marketing team, and as well as the sponsors of this program, Medtronic, and as well as other pharma group for this wonderful CME program here. Thank you once again. Please join all of us for the dinner as well as with the cocktail. Thank you.